So what we're talking about here is a lesion in the pons, and the pons is fed by the pontine arteries, that part of the posterior circulation. And if we have a lesion in the pons, that will affect the lower motor neuron. Now here's what happens. We've got signals coming from this part of the primary cortex. We've got face signals coming from the right primary cortex, motor cortex, and we got facial signals coming from the left primary motor cortex. They come down successfully. They hit this ganglia successfully, and they transfer onto the one train, which takes all of that information down to the left forehead, but the tracks are broken. So the signal stops, and we can't control the motor forehead on the left side of the body. So we get hemiplegia in the left forehead, which means that when in the real world we see a patient and we say to them, as I'll show you how to do in a neuro exam, first thing I'd like you to do, ma'am or sir, is lift up your eyebrows really high like that, so that you're really surprised by what I'm asking. And I look at the folds. See how I got folds in my forehead? If I had a problem in my lower motor neuron here causing hemiplegia in my left forehead, so right, left, it would look like this. I'd say to them, can you, pretend my hand's not here, can you lift up your eyebrows and go like this for me? And they'd go like that. And this part of the forehead would, I'm not sure if I'm doing it well, but this part of the forehead would be wrinkled and this part would stay flat. So we've got hemiplegia in the left forehead, and just the left forehead, not both, just the left forehead, which means that must be my motor neuron, my lower motor neuron, which is innervating there. So I must have a lower motor neuron lesion, which means that's coming from the pons, which means I've got some sort of a CVA in my, just in broad terms, in the posterior circulation. So left forehead means I've got a problem in my lower motor neurons, particularly in this case, the left one, and it can also work the other way, right? So if we had a motor neuron lesion here, I'm not sure if I put it into the slide, but if this one was coming down and we had a lesion on this particular region of the pons, then it would be affecting our right forehead. So you can have isolated right or left forehead hemiplegia, and what that's indicating is a problem in the lower motor neuron. Make sense? So when we take a look at someone's upper face, when we take a look at their forehead, we're looking for a few things. And if you take a look at how the nerves actually innervate, they actually innervate from below the eyes up. So if we're going to separate the face, we basically draw a line, as I've drawn here, from the bottom of the eyes up, and the lower motor neurons coming from the pons will go into the forehead here. And so there's three things that we can check to see how well they're perfusing or innervating the upper face. The first thing we take a look at is what I've just described to you, which is the forehead wrinkling. And we ask them to lift their eyebrows up and see if the forehead wrinkles on both sides. The other thing that we look for is something called the palpebral, I'm not very good at that, fissure. And that's not ptosis. Ptosis is a drooping of sort of the face. So you may have learned about ptosis as a sign for stroke. It's not a great sign for stroke. So this is me doing my Mythbusters thing here. Don't worry so much about ptosis in a stroke. What we're looking more for is the palpebral fissure. And the palpebral fissure is the space between the lower eyelid and the upper eyelid. So right now my palpebral fissure is closed and right now it's wide open. So how much of the eyeball can you see? That's the palpebral fissure. And if they are having problems with innervation, they won't have very much motor control and their eyes will kind of be wide open. So if they've got really sort of a wide palpebral fissure, that indicates hemiplegia. And if their eyes are normal, roughly normal looking, if that fissure space is normal looking, then that indicates or suggests that there isn't so much of a lesion. So we can take a look at the forehead wrinkling, then we take a look at their eyes, and we take a look at how much eyeball is showing. The more that's showing, the worse it is. And then we ask them to do an eye squeeze. I'm not sure if you'll be able to see this, but when I squeeze my eyes as tightly closed as possible, my eyelashes disappear. Watch. You can't see my eyelashes anymore. And if I open them up, you can see my eyelashes again. So if somebody is having a lesion to one side of the face and you ask them to close their eyes as tightly as they can, what you'll notice is that one eye will close right up and lose the eyelids, and the other eye, or eyelashes, and the other eye, you'll still be able to see the eyelashes. And that is a demonstration of hemiplegia, or weakness, to one side of the face. So what you'll typically see is if somebody is having, for example, a right-sided lesion, we'll say, can you wrinkle up your forehead? And they go like this, lift up your eyebrows, wrinkle up their forehead. But if they got right hemiplegia, they won't be able to do it. So you'll see this. And then we'll say, can you take a look at me? And you look at them while they're doing it and take a look at the fissure. And if they've got right hemiplegia, that fissure will be wider than this one. So they'll look kind of like this. And then you say, can you close your eyes as tight as possible? And this one, the eyelashes will disappear, but this one won't. So 3 fairly clear signs of hemiplegia looking at the face. That's the lower motor neuron. Now let's take a look. We've taken a look above the eyes. Let's take a look now below the eyes at the lower part of the face. When we take a look at the lower part of the face, we're getting further down the primary motor cortex. And like the upper face, we've got an upper motor neuron that comes down to a lower portion of the pons and then decussates over down to the lower face. So far, pretty much the same. The difference is that with the lower facial neuron, we don't have bilateral innervations by the upper motor neuron. When we were looking at the upper face, we had the right and left train tracks coming into the train station, and then the lower part going down to this face. With the lower part of the face, there's nothing coming from this side with the dual innervation. We don't have dual innervation of the lower face. So if we have upper motor neuron lesion, this again would be a right cortical MCA CVA. So if we go zap here and the middle cerebral artery is starved of blood for whatever reason, and this part of the primary motor cortex becomes ischemic or hypoxic or necrotic and doesn't work, then the signals don't come down. And since the signals aren't coming down here, and since with the lower face there's no dual innervation coming down here, then we start to have troubles with hemiplegia in the lower face. So it's the same basic idea as what's going on with the upper face. The only difference is that we don't have upper dual innervation. So let's take a look at what that would look like in the lower part of the face. We're looking for a few things when we do our clinical examination of the lower part of the face. So we've got our nasolabial fold. So naso obviously means nose, and labia means lips. So nasolabial fold is this fold that comes down here. And if we have hemiplegia on one side of their face, that part of the nasolabial fold gets flattened out like this. So their face looks a little bit like it's melted. And when we ask them to stick out their tongue will protrude over, pointing towards the side of the lesion. That's the rough clinical rule that we have. So if the tongue points out to the right, then we've got, no, it'll point out to the left, I think. Oh, I'll have to check that. Sorry, I'm screwed up now. But I'll check it and I'll post a little note up here. Here it is. Ta-da. Telling you which way the tongue points. And then we ask them to smile. And when they smile like this, that's a good bilateral smile. That's a pass. But if they've got hemiplegia, they'll smile like this. So we'll see the flattened labial fold. We'll see the tongue deviation when we ask them to stick out their tongue. And we'll see that they can't smile on that particular side of the face. So this is the first part of our focused neurological exam. We do above the eyes and we do below the eyes, and we realize where those feed back to in the primary motor cortex and which blood vessels feed that part of the primary motor cortex. Let's keep on going. So here we have the lower facial neuronal pathway, we have a lower motor neuron lesion, which means this part, the lower motor neuron lesion. And we know that inside the pons here, this is fed by the left, by the posterior cerebral circulation and the pontine arteries. So if we have something showing up here, what's it going to look like? Well, it's going to look, in this case, exactly like an upper motor neuron lesion. Because down in the face, whether we break the train tracks here or break the train tracks here, there's only one train basically coming down. There's only one pathway coming down. And whether we break the upper part of the pathway or the lower part of the pathway, we're still going to get the same hemiplegia on the face. So that's actually fairly easy to do. Whether it's up here or down here, it's going to look the same clinically. So that kind of makes it easier for us. So the upper part of the face, above the eyes here, has bilateral innervation from both sides of the primary motor cortex. So we've got kind of like a Y that comes down to, got a Y that comes down to our forehead. But in the lower part of the face, below the eyes, it's a straight line from the opposite parts of the brain decussating down. Take a while to think about that. Make sure you've got it straight. Now let's take a look at the somatic pathways. Soma here just meaning the body. So the pathways that go down to the body. When we start, we're starting in a different part. For the upper part of the face, we started here. For the lower part of the face, we started down here. But here we're talking about the body. And this is sort of in towards the center, which is more top of the brain. It comes down through the pons, but it actually decussates not in the pons, but in the medulla. So this comes down and transfers over to the other side of the body, primarily here, primary motor cortex, coming down into our arms and then a bit further down into our legs. So we're just talking about basically below the neck. Let's make it sort of simple and say that we come from the primary motor cortex, decussate in the medulla, and then affect the left side of the entire body. We've also got one that happens on the other side, so it starts from the left and comes down, decussates to the right side of the body. But again, just to keep it clear, we'll look at one side at a time. So what happens if I have an upper motor neuron lesion? So we're talking about here in the right primary motor cortex, so a right cortical problem. What part feeds here? That's the middle cerebral artery, feeds this region of the brain. And we're going to have a cerebral vascular accident blocking off the blood to here, which means that our lesion is going to occur up here and zap, there it is. So this nerve isn't working properly, and there's no bilateral innervation from the other side of the brain. The upper forehead is the only part that has two motor neurons innervating it. The lower face only has the one upper motor neuron, and the body only has the one upper motor neuron. So if we zap there, what's going to happen? We're going to get hemiplegia in the left arm and the left leg. Easy. And of course, if we had a lesion up here, then that would affect the other side of the body to this. So if we take a look at our patient and we see that the right side of their body has hemiplegia, they have problems with their right arm, they have problems with their right leg, then we can trace that back up mentally in our mind and say that must be the left primary motor cortex. And that's how we can localize what's going on with these patients. So how do we examine the body? Well, there's a few things that we look at. First of all, we think a little bit about the parts of our thinking and our upper body, the brain, the head part, that the somatic nerves feed. So they do feed into the brainstem as well. So we'll get a little bit of vertigo. If somebody's having problems with the vasculature to their medulla or their upper part of the brain, above the medulla, then we'll see this dizziness, which is something that we see in brainstem or cerebral infarcts. We'll see diplopia, which is double vision. So we'll ask them, does it seem like your eyes are crossed? Are you seeing double? If we do the little H test, we'll say to the patient, I'd like you to take a look at my finger, see if they can look at your finger, and say, how many fingers do you see? Is your vision crossed? Can you see more than one of those fingers, or do you just see the one clearly in focus? If they say, I only see the one, that's a pass. If they say, no, it looks a little sort of like I can see two of them, like my eyes are crossed, then that's a fail. Then we say, I'd like you to follow my finger, and we basically draw an H like that. And they should be able to follow with their pupils as you move your finger around. And if they can't, if their ocular motion is somehow restricted, then that's a fail. If they can follow it, it's a pass. If they can't follow it, that's a fail. Then we ask them to speak, and we watch how they're speaking. And if they aren't speaking spontaneously, then we can say, I'd like you to say, repeat after me, the sky's blue today. And if they can't say that, if they're having trouble with the words, we call that dysarthria. They're having difficulty actually enunciating the words. If they're having problems with their language, we call that dysphasia. And that's a little bit, there's a little bit of a subtle difference. So dysarthria is difficulty with the mechanics of articulating something. So I can't speak properly for you. It would be an example of dysarthria. That's dysarthria. So when you see your patient struggling with the mechanics of enunciation, that's dysarthria. Dysphagia is a problem producing the actual language. One of the classic ways for testing dysphasia is to pull out your pen and ask them, what's this? And when everybody knows what pen is. So when they look at that, they have to then take the image of the pen and formulate the word in their mind. So this is language creation, and then produce the word. And often what you'll find is if people are having problem with dysphagia, well, let's do it this way. If they're having problems with dysarthria, they say, pen. That's dysarthria. If they have problems with actually producing the concept of pen, they'll go, yeah. And they'll say, can you say the name of this? And they'll go, yes. And you'll say, can you say the word pen? And they'll go, And they won't be able to actually say it. Now, they will be able to produce words, and when they do produce words spontaneously, like they'll go, yeah. They're not going, yeah. There's not problems with dysarthria. There's problems with dysphasia, the actual speaking. The other thing that you'll notice in people who are having problems with the neuronal pathway to the body is that they might have dysphagia, which is problems with the swallowing. I remember dysphagia is gulping. It's got a G in it. So they can't gulp. And that just means difficulty swallowing. So often these people will be drooling, and they'll have difficulty with actually coordinating their swallowing, and you'll see them struggling with it just spontaneously. They also have ataxia, which is difficulty coordinating their movements. So sometimes they just won't be able to, if you say, touch my finger, it'll be and they won't be able to actually get their finger to you. If you see them walking spontaneously, don't make these people walk because they'll fall down. That's bad care. But you'll see that they have ataxia. They'll have difficulty coordinating their actual movement. And they'll obviously also have hemiplegia, hemiparesis, which are synonymous. They mean the same thing, but they just basically mean weakness. And the way we test that, you should already know, is by what this lady is doing here, and that's doing the pronator drift. She's got very pronounced right pronator drift. So she did the pizza box test, and when we did that, her right hand started dropping down. So now you've got a focused neuro exam. You know how to examine the three broad regions that we look for when we're looking for somebody having some sort of pathology in their presentation. Above the eyes, below the eyes, the lower face, upper face, lower face, and body. This is the body exam. We've talked about the upper eye exam, we've talked about the facial exam, and now this is the body exam. So you've actually got a fair bit to practice here in terms of, in your neurological scenarios or with your actual patients, what am I going to check? And more specifically and more usefully, what does a fail in each of these actually mean? So something else to practice. Go study. Let's start putting it all together. Here's the wiring of our brain. Here's the wiring of our upper forehead. our upper face, which we have our lower motor neuron coming into the ganglia in the pons, and we have dual innervation, the only part. So this is the Y. Why does it go to the forehead? I don't know. If that helps you remember, that's great. So we've got the dual innervation to the upper part of the face. We've got the unilateral, the one-sided innervation to the lower side of the face, and we've got the one-sided innervation to the lower side of the body. That's how we put it all together. So now, I'll do my best evil scientist impersonation, because I'm going to start damaging this theoretical person and start giving them lesions, and we'll take a look at how those lesions manifest. So my first one is going to be a right-sided cortical middle cerebral artery cerebrovascular accident, which is going to wipe out all of this part of the brain. So let's take a look at this from top to bottom, what's going to happen. First thing I'm going to look at clinically is their forehead, and I'm going to say, is their forehead going to be affected by this? Well, this pathway is good, this pathway is good, this pathway is good, this pathway is good. Uh-oh, here's a break in my signal, so I'm not going to be getting information from my right primary motor cortex. But, pas de problème, we're okay, because my left primary motor cortex will take over, and when I have a lesion there, I did it in a slightly different order. That's a bit of a giveaway. But the upper part of the brain is going to be okay. Or the upper part of the brain, sorry. The upper part of the forehead, the upper part of the face is going to be okay. They'll be able to bilaterally wrinkle. They'll have a normal palpable fissure on both sides. And when they close their eyes, you won't be able to see either of their eyelashes. But what's going to happen to our lower face? Well, our lower face here is fed by this signal. So coming up here, we're okay, we decussate fine in the ganglia, we come up and uh-oh, broken. So what that means is we're going to have hemiplegia in the lower face. So flattening of the nasolabial fold, we're going to have deviation of the tongue, and we're going to have an unequal smile. The left side of the face is not going to be able to smile properly. So my right side will smile fine, my left side will stay flat, it'll be like this. That's how they'll look. What about the body? Well, if we take a look at this somatic nervous pathway coming down here, well, we'll start from the body. We start from the body. This is okay, coming through the spine and out the spine to the limbs. We go back up into the medulla. This is okay in the lower motor neuron. The decussation is fine. We go up, Uh-oh, broken signal. So that means this part of our body is going to be hemiplegic. And now you can see what I was talking about at the very beginning of the lecture. If somebody has a stroke, is it one side of the face and the same side of the body, or one side of the face and the other side of the body? Depends on where it is in the brain. If it is an upper motor neuron lesion, if we have a problem with the lesion being up here as opposed to down here, up here we get the same side of the face and the same side of the body. This is an upper motor neuron lesion, a right-sided cortical MCA-CVA. Damage up here doesn't affect the forehead because we've got bilateral innervation. It does affect the lower face, and on the same side of the body as the face, we get limb and less so leg weakness. So when we see the left side of the body, but not the forehead, being affected, then we can, in our imagination, because we've memorized all of this, hopefully, we can trace that back up and say, well, the forehead's spared, so it's got to be above this ganglia. The forehead's spared, and it's the same side of the body, same side of the face and body, so it's got to be up here, an upper motor neuron lesion on the other side of the brain in there. See how it comes together? How cool is that? Now we've just sort of made that aha moment of this is how it manifests clinically. Let's move on a little bit more and take a look at if we did it on the other side. I'm going to take out my evil ray gun and I'm going to zap you up here. So you guys should be able to figure this out now. What's going to happen to my forehead? I've got dual innervation, so my forehead will be spared. It will be bilaterally equal. There will be no hemiplegia. What's going to happen to my lower face? My lower face is going to have hemiplegia. what's going to happen to my body? Well, this is damaged here, so my lower body is going to be damaged. This is right side of the body. We know it decussates, so it's got to be the left side of the brain. Forehead's not affected, so it's got to be above that ganglia. So this is a left-sided cortical middle cerebral artery cerebrovascular accident. So you can start to localize roughly where this may potentially be in the brain. So this is what we were talking about with our classic MCA CVA. We've got forehead sparing. So the CVA here is on the left side of the brain. We've got forehead sparing on the right, and we've got right-sided facial and body weakness. And if you read Tintinelli or Rosen's emergency medicines or classical medical textbooks, this is how they will describe them. Most of the CVAs that we see in the field are MCA CVAs. In fact, about 70% of all the CVAs, the ischemic CVAs that we see, are middle cerebral artery CVAs. That tends to be where the blockage occurs. So this presentation with forehead sparing and ipsilateral face and body weakness, ipsilateral means the same side, is the classic one that you're going to see. And this is the one that we classically teach in paramedic classes. We don't talk about the forehead because it's kind of confusing, but just to keep it simple, we say if it's the right side of the body, it's the left side of the brain. And if it's the left side of the body, it's the right side of the brain. But it's true, but it's only true with middle cerebral artery cerebral vascular accident, which is most of them. So this is your bread and butter stroke. This is what you'll see most of the time. Isn't this cool? So let's go on a little bit more. And here we have from Rosen's emergency medicine and Tintinelli's emergency medicine talking about the presentation. And this is why most people say that, no, it's always the same side of the face and the same side of the body. It's not always. It's only with an MCA CVA. So it's not always, it's about 70% of the time. All right, so let's take out my evil ray gun and zap you somewhere else. Let's go into a left-sided pontine CVA. So I'm going to start zapping the pons down here in the lower motor neurons. So we've done upper motor neurons already. Let's go down to the lower motor neuron and take a look at what happens. So here's my zap. And I'm going to trace back up from the body. So I start on my forehead and I go up and I say, do I have good communication to the primary motor cortex? No, I don't, because the lower motor neuron is zapped, so I've got hemiplegia here. Let's think about my lower face. I go up. Do I have good communication to the right primary motor cortex? No, I don't, because this part is zapped as well. So the entire side of my face is zapped. There's no forehead sparing. I've got hemiplegia in the upper face and in the lower face. What about my body? Is the left side of my body going to be zapped? Well, if I trace up, the left side of my body is actually going to be okay because it crosses over here. So it's the right side of my body that is actually being affected, and we get this crossover pattern. So we see upper and lower face and the contralateral side of the body affected when we have a pontine CVA. When we have the vascular accident affecting the nerves in the lower motor neurons in the pons, we get what they call the crossover sign. So when we have unilateral, we have upper face is spared, lower face is hemiplegic, and same side of the body is hemiplegic. That's the upper. But in the lower, we have no forehead sparing, and we have this contralateral crossover sign. So it depends on where in the brain the lesion is. This is the classic presentation of a pontine cerebrovascular accident. What if it was the right-sided pontine cerebrovascular accident? Well, in that case, we're doing it down here, and we're going to get our right forehead hemiplegic, our right face hemiplegic, and the left side of the body hemiplegic. So again, because it's a lower motor neuron, we have upper and lower face, and we have the contralateral side of the body. So this is our lower motor neuron. We have no forehead sparing, The CVA is on the same side as the facial hemiplegia, and then we have the crossed findings where the contralateral part of the body is affected. So this is posterior circulation because it's the brainstem. So the hallmark of posterior circulation or brainstem stroke is these crossed findings with the ipsilateral side of the lesion. So ipsilateral is the same side, face and lesion are the same side, and crossed over to the contralateral side of the body. This is fairly uncommon. And it's why paramedics, when they go out and they say, but I've seen people with one side of the face and the other side of the body, we say, yes, that's because it was a posterior stroke, not a middle cerebral artery stroke. So you'll see both.